Good morning, and welcome to episode 5 of Align Health Insights. This is Mark Czubachowski with MCZ Align, and these are my guests today, the co-founders of FwdSlash, Josh Prasad and Samir Sood. Welcome, gentlemen.
Good to be here, Mark.
Hey, Mark. Thanks for having us.
Well, it's no strange coincidence that I am also an advisor to FwdSlash, so this may be a little bit more biased than my other interviews. However, I really love what these guys have been able to accomplish in the housing space, and I think we're really excited. So let's get into it, gentlemen, if you don't mind. So look, I think as a starter, let's get into your backgrounds. Could you guys briefly tell my audience about yourselves? Josh, maybe you start, and Samir, you can follow right after.
Sure thing. And Mark, thanks for having us. We're excited to talk about all the fun stuff. I'm Josh Prasad. I'm the chief operating officer at FwdSlash, but I started my career I guess about 15 years ago in public health and really focused on health policy. I got my start doing a few local and state health policy things, but really jumped in at the U.S. Department of Health and Human Services. And I spent 5 years there working on chronic disease prevention, which sort of turned into this bigger understanding of the social determinants of health, social drivers of health, that really impact an individual's health outside of the clinic. Those factors are some of the things that are most important to the way people's health is experienced, and really got to inform federal policy on that when I was at the department. Outside of government, I founded my own startup focused on community health workers, which I am the first one to say didn't really work out back about 10 years ago, but I learned a lot about building companies and failure in that process. I ran a small health center in rural Maryland, focused on addiction that I helped convert into an integrated behavioral health center. Spent a couple years at a big consulting firm called Deloitte, where I focused on Medicaid innovation and social determinants of health, and then was asked to come back to the Biden administration and be the director of health equity innovation again at the U.S. Department of Health and Human Services. Did that for a little bit. I also moved on to HRSA, which is the Health Resources Services Administration, and was their director of innovation at the Center for Innovation there, until I left to co-found FwdSlash with Samir. And so we'll get more into what FwdSlash does, but yeah, that's me in a nutshell.
Great background, Josh. Samir.
It's a big nutshell to follow.
It really is.
Yeah, well, thanks again for having us, Mark. Yeah, I'm Samir, CEO at FwdSlash here. Family medicine doc by training, further back by training, biomedical engineer, which is often how I think about the world and systems that we're in. Been also a serial entrepreneur throughout my medical training, including right before medical school when I first joined my first healthcare startup and got out to HealthBox in Chicago, seeing what innovation is and the future of medicine, so to speak. That was about 15 years ago now, and I'm still waiting for the future of medicine to happen at some level. But
yeah.
It's been a great journey. I co-founded another company in 2015, my first one, called Sherbet Health, which is sort of early RPM, remote patient monitoring, before RPM was really a thing. Really good example of sort of building a beautiful solution and then finding the problem to solve there. A mistake I've not wanted to repeat. Since then, that was during my third year of med school, kind of paused school for about a year and a half or so to kind of work there. Worked at Accolade on the healthcare innovation side as well, under the VP of operations. Accolade was a pretty good experience with a different side of primary care that I was exploring. Then went to Duke University for family medicine residency, and finished residency June 2020. So kind of prime or early COVID. And then kind of wanted to do something different with my life. So did a couple different things. One, didn't take a clinical job at a hospital or anything, couldn't really stomach that, but went into locums, which is contract medicine, went out to some rural places like rural Minnesota and worked with a tribal population there at the IHS, Indigenous Health Services, followed by some special needs medicine work in Louisville, Kentucky. Actually, that's where I work now, with the IDD, intellectual and developmental disability population in Nashville, Tennessee. But sort of at the same time, co-founded FwdSlash was building or looking and exploring as to how to actually make a dent in the upstream causes of health that I saw in residency, again, family medicine residency, so birth to death medicine, and seeing all the areas that I couldn't really do anything as a physician. I got to go be an entrepreneur in residence at Elevance Health in 2022, really
Yep.
exploring, I guess, the data and financial side of social determinants and social drivers, which really helped build the housing model that we currently run through FwdSlash. Up and running now a couple years later.
Awesome. Yeah. It's funny. I've been with you on a lot of that journey. I just remember some of those experiences, like the IHS as an example, really eye-opening. I've learned so much through you both. So look, what is this FwdSlash? What is it? I know what it is, but tell my audience.
Yeah, we were really interested in exploring the nexus of what we consider healthcare and the broader social impacts. And so we just kept writing health/social care over and over again, and we realized that we want to be right in the middle of that health and social care piece. So that's where we came up with FwdSlash.
Yeah.
Just a way for us to be right in the middle of stuff.
Right on. So health and social care, right? Maybe go a little deeper on what that exactly means. I mean, that could mean so much, right? Like, look, I'd hate to, and I'm not going to say anything negative, but we've had this preponderance of social determinants of health companies being capitalized, right? But when you look under the hood, what are they? They're really, quote, social determinants companies that are data aggregators, right? And it's really hard to, tell the difference or the nuance as an investor between them and say, IQVIA, it's just another data set. But I mean, really, I think what I'm trying to illuminate here, Josh and Samir, is that last mile problem, right? So maybe you can, just go a little deeper on what exactly you're doing and what you've done for some of these communities that you're serving.
Yeah, I mean, I can start maybe a little more with the origin of it. I think it literally big picture came down to how do we actually implement or affect rather the design of the communities that we're in. I mean, there's either such beauty around us, and Josh and I have experienced that in various places that we've been, natural beauty to well-designed communities abroad or hopefully locally. But we've also seen the dark side of that, where it's built and designed according to a different set of outcomes or values that have nothing to do with health. And it's very, very clear then, based on outcomes that we're seeing or outcomes in those communities as to why health is not being generated. And so it comes down to the design. And so the big question has been, how do we actually affect the design of our communities that people live, work, play, thrive, or lack thereof in? And so we explored really early on, literally novel ground up design. We were talking to groups trying to build and design a health community on 100 acres of land, 25 acres of land, multiple acres of land all over. And we were just, what is housing, food, safety, green spaces, health, comprehensively look like? Didn't really get a chance to do any of those at the time, but kept exploring. Started talking more to food systems operators and housing developers and community organizations and nonprofits that do this great work, realizing that there's just such potential and value if recognized, as to how housing is developed and designed, as to how food is procured, delivered, and in the right sort of ways with the right measurable outcomes, and all that didn't exist. Or wasn't recognized at the time, maybe even still for the most part, as to how housing developers could influence health if they worked in the right ways and were incentivized and enabled in the right ways. So yeah, I mean, I think taking that further, we've liaised with a lot of housing developers. In fact, we have a housing development team that helps us develop how we procure, develop, acquire, lease housing units. And kind of mixing their expertise with our expertise in the health space, mixed with sort of the insurance, value-based care, Medicaid side of everything, and that through line and I'd be remiss to not mention our community-based nonprofits that have been doing housing work for decades, but have never been part of the healthcare value chain. So enabling them, most importantly, to do their great work, but under a healthcare, measurable outcomes, health outcomes driven way has been really, really cool.
Awesome. I mean, look, one of the things that I think is genius about this model, and one of the things that you really haven't mentioned, is that you're not trying to reinvent a lot of the good work that is being done in these communities. You're just trying to amplify it, right? Through things like SOC 2 and high trust infrastructure as an example, and enabling these community-based organizations to be the recipient of benefits that they deserve, but they are not currently getting because they're not wired into the system, right? So can you just get a little bit more granular? And then we're going to, kind of shift and talk about some of the macro trends in healthcare. I just think it's important, and maybe even substantively talk about some of the things that are going on in places like Sacramento and in West Virginia and in Kentucky, right?
Absolutely. So like Samir said, we've not only been talking to and connecting with the local partners on the ground. It is a community first model. That's what we decided when we built this thing, was that we want to work with communities and help enable them to really take control of their health and social care altogether. The way we do that, or the way it started, was just by doing it. So I started in the policy space. I worked at the federal government. We talked about social determinants of health. Startups and government and everyone in between was talking about social determinants of health. And at some point, we were just kind of tired of the talk that we can say, let's get people housed, or it's your community's responsibility to house people, and that will improve their health by X number of outcomes or Y dollars. But we weren't seeing a lot of the health actors really take on the responsibility of doing that work. And so that is literally what we did. We, in our first contract in West Virginia, we just went out and procured a dozen housing units, master leased them and rented them and kept them off the market for a couple of years. We used the capital that we raised to do that, and then built a model that allowed us to house folks with the local housing community-based organization, the West Virginia Coalition to End Homelessness, who Samir referenced before, and in partnership with the health plan there, that we were able to link all of these pieces together and really track the outcomes that happen when an individual or family is housed after being unhoused for a long time. And in that model, we were able to show upwards of a 50% cost of care savings, total cost of care savings, largely based on an 83% reduction in emergency room utilization. So
wait,
get people
so 50%,
housed.
50% cost of care savings. And what was that 83% number again?
83% reduction in emergency room utilization. And so basically, when you're unhoused, you're going to the emergency room a lot. That costs the healthcare system, the hospital, the insurer, whoever, a lot of money. When you're housed, we're using rental subsidies that are provided by HUD or a local housing program. Those are dollars allocated for housing, and we're shifting the cost from the emergency room, which costs 12 times more, compared to just using the actual allocated subsidies. So it's a coordination effort, but it's really us taking on the responsibility of being their landlord as well too, and being their service coordinator and working with the local partners there too. The other piece I'll mention about this community empowerment thing is that we don't intend to go in and take over communities with our affordable housing developments or anything like that. We want to work with the local partners to build those community first models. What Morgantown, West Virginia needs, what Northern Kentucky needs, where we're working as well too, or our partners in Sacramento or Seattle or North Carolina, is local affordable housing, or housing that really understands a low income population, that will allow them to thrive in that and improve their health as a result. And so that's what we're doing with our development partners here. It's not us coming in building luxury condos and then and trying to take over the blocks here.
I just think it's really important to illuminate those numbers as we move on down this podcast, and potentially I may start, asking you guys about a counter narrative to the traditional venture capital model, long-term stakeholder alignment, and double bottom lines. I think it's just really important for our audience to kind of stick those numbers in the back of their heads for pray tell what's to come in the next 20 minutes or so. So okay. Look, so I think it's time to take a pause here and just like really think about like the general macro trends. I'll start by saying something, okay? Like Healthcare Dive magazine last October, I think, or something, just stated the fact that over the past decade, right, $60 billion has gone into digital health, guys, $60 billion. Over the last 5 years, the majority of that capital has been deployed. Now, this is just facts, right? And by proxy, right? And I'm not saying this is an overall benchmark for success, but companies that have focused on health systems, and I'm talking technology here, which this isn't a pure tech play, but we are building technology. 5% of those companies, 5%, have matriculated past the C round. And just for fun, life sciences companies that have been focused on life sciences, 10% have matriculated past the C round. And companies that have focused on payer, healthcare technology companies focused on payer, 16% of them have matriculated past a C round. So look, I'm just saying, from a mere returns perspective, look, we're talking mission-driven work here, but there's a business case that I really want to talk about. And the return of an invested capital, overall from the venture capital community has been marginal, at best, right? So that's what we're talking about here. What do you guys, see, as some of those more broader macro trends in the past decade, as it relates to innovation? I'm just curious as to what your takes are here.
I'll start. Everything you just quoted has been, the singular metric by which venture capital and the funding communities measure themselves by. They might quote outcomes, they might quote cost reductions and life expectancy and such, but their own metrics of success are actually marginal, to your point. And so that's what we've been asking ourselves, and we've been part of venture capital raises of previous companies and such as well. And so did we want to measure our measure of success based on Series A, B, C, D, IPO, mergers, acquisitions, whatever it might be, exits? And the answer has been no, because one, that's been marginal, but two, doesn't actually speak to the outcomes that matter. And so the other half of the outcomes spectrum here are actual health, chronic disease rates, homelessness, food insecurity, all of which have been rising, in a laughable curve next to the funding curve, although funding curves have dropped off over the last couple of years as well. But nonetheless, all this money getting poured into healthcare and innovation is not actually touching, to me as a physician, the things that matter in terms of life expectancy, which has been declining, rates of obesity in adults and children, increasing, fatty liver disease in children increasing, homelessness year over year, we're up to about 750,000, up from about 650 last year. Rates of housing insecurity upwards of 4 to 8 million by some estimates. Food insecurity rising as well. So big question is, what are we actually doing with our money, with what we call innovation, and what problems are we solving? That's all the questions that have been on our minds. Josh, anything else to add there?
No, I think that's spot on. We have been, I think Samir and I were part of, Samir and I were part of a innovation fellowship 10 years ago. We were, I guess, just kids back then, relatively, and have really been interested in the space for a long time. So it's been, there's this alluring side to what they call digital health or healthcare innovation, health innovation. I've also done it in the policy spaces as well too. There's a lot of opportunity with that. But I think we need to, what we've seen is a lot of money spent, like you just said, Mark, or invested into kind of the wrong buckets, if that makes sense. You're sending it to potential stewards of those dollars to then go use them in the ways that they think make the most sense, and that also make a profit. To your point, Mark, there's definitely a way to make a profit and do good work at the same time, and help the communities that need it most. We often don't draw that straightest line to helping those communities, and I think that's part of the misalignment here. So how do we actually draw that straighter line to those communities? I think that's something that we're trying to explore and figure out, and that won't be measured in seed rounds, because we don't, the venture capital firms are not dropping dollars into community land trusts or things like that in the series round. Yeah. Maybe they should, but maybe there's new ways to think about stuff. Yeah.
Well, look, I'm not in love with the All In podcast guys, but I'm in like with them. They do say some good things, but it really does illuminate. When they talk about things like total value of paid in capital and distribution of paid in capital being like the benchmark metrics for venture capital firms that are really beholden to their limited partners, right? What I'm saying is actual cash distributions, right, is really like the end all be all of the benchmark to success for any venture firm, right? So if that's what your endpoint is, right, but you're serving a stakeholder that doesn't really care about that endpoint, how are you long-term aligned to that stakeholder is like a really broad question that I think a lot of people are murmuring in healthcare, right? I mean, look, I get a lot of my customers are venture capital backed companies. I think that they serve a purpose. But again, I think that this is one of those things that I hear being whispered at conferences, that I'm talking to a lot with industry professionals. There just seems to be an overall lack of long-term alignment, right? And I hate to say it, but it's true. And I just really, what I got so excited about here, and I think what I'd love to get into is what that potential counter narrative could be, right? And it seems so obvious. It almost like hits you directly in the head, but that seems to be, what we're building here. And we can start talking about things like taking investment dollars from our community partners as a starting point, right? But I don't know what you guys think about what I just said. It's pretty bold. But again, really everything that I say here really is just an echo of, the myriad of conversations that I have on a weekly basis with people in our space.
Yeah, I mean, I'll start with the familiar term of strategic investors, right? I think everyone knows what that means. That sort of the customer being the one to invest and be an end user of the product. And in our case, we're working in communities, and there's no one that has a more vested interest in the success of that communities than the community members themselves. We mentioned my work in Minnesota, and I'll quickly double click on that. Working out with a tribal population, middle of, it was 3.5 hours east of west of Minneapolis, hour east of Fargo. Healthcare desert. I was probably the only adult provider for about a 30-mile radius. But what was there, if not, healthy food access or healthy providers or enough providers per se, was community. Nurses who knew every patient, who are of the community, who have been with these patients their entire lives, that know them by first name, know their spouses and their families. When they were sick, they would get hugs just from because they were all in touch with each other, and it was such a beautiful level of care, so far beyond what I've seen clinically, kind of in coastal medicine spaces. Nothing against coastal medicine, but it's just a different world when it gets more rural and when it gets more community centric, where everyone just knows each other. Citing West Virginia now too, our peer support specialists are folks who were formerly unhoused themselves or formerly had substance abuse disorder themselves, and now they want nothing more than to help others like them and to hug everyone who walks in their door. And it's just such a different mindset, and you can't scale that necessarily from like a headquarters in whatever big city out to these communities. That's not scalable. And so, one, from a service and talent standpoint, that's who we procure services from. But two, investment and funding. I think the question's been, how do we switch this, change the narrative of how do we get funders who are not from, again, some big city somewhere, but are from literally these communities themselves. And unfortunately, these are not organizations that typically invest or have wealth-generating vehicles like investing to be a part of. So a lot of our work actually has to do, how do we enable them to become investors and take either their grant dollars or whatever extra cash they have lying around and turn that into a strategic investment into themselves, into their communities as nonprofits, where any exit and return potential or follow-on funding actually becomes higher value for them to do their work better.
Right. Josh?
Yeah, I'll just add in, or I'll go back to Samir's experience in Minnesota. I had the pleasure of visiting him and checking out the clinic and stuff too, and really seeing what life looked like out there. And he mentioned that he was probably the only adult provider for pretty good distance.
Hmm.
But what
I
was there
remember.
in that community was every fast food chain you could think of, every big box provider,
Oh yeah.
every other corporation that is trying to monetize unhealthy behavior in some way. They found their ways out there, but we can't seem to find, in a macro sense, the providers needed to ensure that they can counterbalance those negative health things. And I'm not going to say any specific company or anything like that, but we know what fast food is. We know what unhealthy food looks like, for example. So I think the bigger trend, and this is true of pretty much every community that we work in, is an underserved community. And that doesn't there's no individual or running through line of what that phenotype of community looks like. Every community is different, but they are sort of forgotten in the social and healthcare space in some way. They don't have enough providers. They don't have enough resources to house everyone or provide the healthy food options that they need. And so I think that's part of the realignment that we need to see is how do we start investing um, in those macro things that keep people healthy. The big box providers, the fast food providers, they somehow found their way to a place that is otherwise apparently unmonetizable from a healthcare perspective, but they're there. And so I think we need to, whether you're in venture, private equity, or on the government side, and thinking about how we need to rethink how we get dollars to these communities that actually need it in a sustainable way.
Yeah.
That's actually it.
Yeah. Hey, Samir, I think you may have read The Fish That Ate the Whale.
Yeah, great book.
Sam Zamari, right? Well, he has this quote in that book that I think is just so poignant here. They're there and we're here. We're here and they're there, or something like that. You know what I mean? And that's exactly what you guys are saying. It's like boots on the ground, experiencing these things daily, living in it. Those are the people that are going to solve the problems, because those problems are more meaningful to them. I mean, it's like the old analogy when, the pain hurts, you want to stop it immediately. I actually had the privilege of doing, 2 week-long trips through rural Appalachia and the Georgia Black Belt, in a car, visiting with a bunch of critical access hospitals with a colleague. And I saw the same exact things. It was pretty illuminating seems to be, that's my word of the day, illuminating. A lot of the lack of healthy food options, for sure. Amidst a beautiful landscape with, some towns that were quite frankly abandoned, and I think, I don't know, was it 20% of our population in the United States approximately, or is it more? I don't know. I used to know the statistics. But yeah, so look, I mean, there's a lot to get into here though, guys, right? So like, clearly, like when we look at this from, an outcomes and exit perspective, this is like, the first order, is making these communities more healthy, more wealthy. You know, there's really not an emphasis on like some large, cash exit for FwdSlash. That's really very secondary. Um, but it's not just FwdSlash, right, guys? I mean, it's like this opportunity for a couple different things, right? It's opportunity for a housing fund, and strategic payer partners and health system partners, and really focus on that double bottom line of the stakeholders that are already investing in those assets anyway, where they're getting a return, which is about 7%, right? And then, the double bottom line of the better health outcomes. There's the studio to talk about, gentlemen, and Braided, which we're building right now. We could talk a little bit about that, but then the opportunity to get some funds to start addressing and creating new companies that would be invested in by these community-based organizations to address additional problems that are going to come up, right? So why don't we, break down into the big elephant that we're trying to eat here? Why we're trying to eat the entire elephant, which just seems like crazy, and like,
I mean,
quite
that's a good
frankly, we've been
question.
advised against it like numerous times, and we're still doing it. Why? So why don't you guys just talk about the different things, and why we're taking such a big endeavor.
Big animal. Yeah, I mean, I'll actually go back to a point we were just talking about in terms of, raising from strategic being communities. I think it's also a question of who do we want to be held accountable to? again, is it those who just take board seats, who live in different cities? They are there while we are here, kind of to your point, Mark. And we want to be accountable to the right stakeholder, to the right end users and communities that we're working in. Because if we're solving, we're solving the right problem, then we're building the right technology or right solutions, way beyond technology. And so to get into to your point just now, or question just now, we took a very tech second approach. I think we've both seen, ooh, let's like build an app, or let's build a digital health platform.
So wait, you're saying that agentic AI is not going to solve all our world's problems?
If you don't know the actual boots on the ground needs, if you haven't been of the community or of the end user yourself, then what are you training, like from a bot or agentic AI standpoint, or a model standpoint? So for us, quite literally, we became landlords first. So master leasing in these communities, Morgantown and Northern Kentucky and the Covington area, partially because no one else was going to put up housing units to house a high need unhoused population, and partially because it gave us the opportunity to explore and be part of the team on the ground level, with our case managers, with health plans, while also kind of coordinating the services across all of the domains there. But yeah, I mean, the stories we have out of Morgantown, West Virginia as a landlord are not for this podcast.
No.
In case there's any kids listening here, but yeah, it's pretty eye-opening, and all of it has been learning lessons for us on how to create solutions, in West Virginia, in Kentucky, in Washington, in North Carolina, in California, wherever we're working now. And I say solutions to mean more broadly than tech or AI or whatever kind of buzzword of the day we have here. So yes, where there is sort of a tech solution that we're building now based on what we've noted from the model, the low tech, high duct tape model we kind of created to start. And there's also sort of the housing procurement piece, is how do we actually create housing supply here? And again, that's not necessarily technology. It could be, and there's some great examples out there. But net new supply and control of that supply in an equitable, community-centric way has been the big question. And that's sort of our health prescribed housing work that we're doing. But then also, looking at our environments and noting that, okay, with housing insecurity comes food insecurity and transportation insecurity, job and income insecurity. Like, how do we start to create these other solutions around locally sourced, medically tailored meals versus Silicon Valley sourced medically tailored meals? And so I think that's where the studio environment or model has come to play. And I think, again, venture studio is what's classically known as a way in which to create multiple solutions and kind of de-risk it most of the way. But in our case, it's a community studio. It's for communities, by communities, invested in and owned by communities as well, as part of our funds that we're going to deploy in solutions that serve these communities. Yeah, so that's kind of the approach we've taken to one, understand needs first and foremost for years before we actually start creating some of these solutions.
Okay, so look, that's the macro picture, right? But just and it's great, right? It's a great vision, but like just to like really bring it down to reality and get out of the ether for a second, like what's being done today on all fronts? If you can give me an example of like where we're at with the housing fund, where we're at with the venture studio, where we're at with Braided, and maybe talk a little bit about Braided and what that is, right? And why we think that there's a unique opportunity to build there. But we are doing things today. This is happening, right? Like, so if you guys can just give our audience a little bit of a taste of what's being done right now.
Absolutely. So we've been working in these spaces for several years now. And like Samir said, it's important that Samir laid out that we
did it
the
totally
duct tape way, the quick way to like work with the community partners so that we can understand their needs really well and design solutions that really help them and empower them most. And so that started with a bunch of different things. It's the housing procurement piece. We started master leasing units. It's a great rapid solution. It's not a great long-term solution. We can't just necessarily in perpetuity keep leasing units and then living in this balance of existing units. We want to empower those local landlords to be good landlords in their community, and we're helping them do that while we also build more affordable housing stock. And so we're just actively doing that. We spent the last year or so in a housing incubator program that helped us develop a model that we call health prescribed housing. We built it originally as a national fund. The idea that we need to get $100 million into a fund so that we can deploy it strategically across communities across the country. And the idea in that fund being, the big game changer here is that we will create a vehicle that allows healthcare, it's health insurance companies, hospitals, and other big sources of capital. They have a vehicle to actually put their dollars into, and it's a real investment for them at that enterprise level. And we believe that healthcare can be and is a good landlord or steward of their community. If you're a hospital, you're a fixture in that community, sometimes for decades or generations, right? And so that's a responsibility that they take on, and that makes them a good landlord in the long term, more so than the national housing luxury condo entity that might be doing the same kind of thing. So how do we get them into the mix? We conceptualize that at that big national level, but we're operationalizing it at a local level. So we're actually building our first. We're building this as a family of funds, really, but our first member of that family is in Northern Kentucky, where we're operationalizing somewhere between a $2 to $5 million smaller housing fund that will allow us to tangibly procure 30 to 50 units and use them for these health and housing programs right away. We've gotten some healthcare partners, some housing partners into that mix, and we're looking to close that in the next few months. Yeah, Mark.
Well, I mean, listen, simple systems that work, I'm a huge fan of, right? And then, adding more complexity in the model afterwards, right? Instead of starting a model with like a gazillion interdependencies that's doomed for failure, right? So this bottoms up approach, I think, is spot on, to be honest. Okay, so that's awesome. Where are you guys at with the studio? And then after that, I'd love, either you can tackle that question, and then after that, I'd love to talk a little bit about Braided and where we're at in that build.
Yeah, I mean, so the studio has been an interesting endeavor. I think we are raising to be able to solve problems better, faster, problems that we've noted now. I will say this: it's an elective raise, it's an elective pivot. This is not out of necessity or survival as an organization, which is kind of, I don't know, the most luxurious position I've ever been in a startup, where we're not raising to survive, or raising to thrive on behalf of our communities. And so sort of taking our time and sourcing the right investors, the right community organizations themselves, or the right organizations and nonprofits that represent communities of high need. So we're talking to a couple right now, kind of getting first money in the door. We've raised probably nearly $500,000 in commitments so far, and looking to raise about up to $2 million, at least in this first iteration of it, to test out the model, see if it has legs. With that, we'll then capitalize whatever we need to on the health prescribed housing family of funds side of things, to be sort of on the healthcare advisory of the GP side of the fund. But then also looking to capitalize further our health IT approach. And really, it's a social care coordination platform enabling non-clinical community-based organizations as providers in healthcare, really for the first time. Primary care docs and specialists have EMRs. Housing case managers at these nonprofits don't really have much as it relates to what helps them contract with Medicaid and healthcare. And so, building that out as a secondary product as well, or solution rather. And then, other things in the pipeline, like I mentioned, locally sourced, medically tailored meals. How do we build the local food system while providing healthy, accessible food sources to a food insecure population, and piloting that in one of our communities in Northern Kentucky?
The existing food solutions out there, just based on your trial and error, don't really seem that great.
So there's some good, we should be clear, like there's some good options that come out there. There's also a lot of challenges to doing it the right way, right? So, I mean, if we think about food options, the supply chain matters, where you get the food from and how it's, that changes the quality of the food. And
Yeah.
so, working with, we found that we need to just get more and more local if we want to provide our clients with, good quality food that doesn't have to be frozen, doesn't have to be, packaged and left on a shelf for a while. And there are plenty of entities within any given community. It's harder to scale that, but we're building just sort of local food networks to do it, and that allows us to solve the real problem that we want to. And that's what we want this studio to be: is help empower local solutions, in a way that they haven't been able to get that sort of scale in possible. It goes back to the Minnesota and West Virginia rural health thing.
Yep.
There's a great HIV researcher, Dr. Peter Muyengi, I think I'm saying his name right. He has a quote about HIV meds being produced. Basically, he said, the cure is where the disease is not. The disease is where the cure is not. And the idea is, like they're making all the meds for HIV, not where the HIV actually is or was.
Yeah.
Really most disproportionately affecting folks. I think we want to change that model. We want to build it. We want to build this studio to really empower all those communities that need empowerment. If we think about VC and we think about all the accelerators and incubators that are out there, they're not really connecting with the communities that need it. So how do we become the studio that can help incubate and grow solutions in those local communities?
And I'll use this real quick to sort of emphasize that it depends on what your mandate is for who you're held accountable to. So those current organizations, they're held accountable to scale, to ROI, to 7 to 10 year exits, and national scale as fast as possible. That is their mandate, and they're doing that. So maybe they're good per their mandate, but that's just not the mandate we want to be held accountable to. And so we're in 5 communities. We're taking on responsibility in health and social outcomes of those communities. And so we have the opportunity to do sort of non-scalable, hyper-local experiments that maybe it's scalable, maybe it's not. Maybe we just solve relative food insecurity in Covington, North Kentucky, and that's okay with us given our mandates and what we set out to do here.
Yeah. You guys have a board of directors?
We do.
Yeah. I mean, so, you guys regularly meet. I'm sure the communication is transparent and you guys are aligned.
Yeah. I mean, it's a pretty small board and made up of folks that we've kind of wanted to be on there. And I think that's part of the reason why we have a lot of control in some of the more absurd things that we do and take on that are not scalable, that are not profitable, that, we've covered things for our clients, again, our formerly unhoused clients now in our housing units that, again, are not scalable, not profitable, but we do it because it's the right thing to do. Yeah. And we have the latitude to do that.
Yeah. I mean, a lot of times, even in the venture world, what I see some really great leaders. I also see leaders sometimes that fail to educate their board down to an 18 to 24 month timeline and corridor to educate them, right? In terms of, where they are exactly right now and where they can be, so that they stay aligned to the organization's mission and that mission's appropriately communicated to their investors, right? Because what ends up happening is when that doesn't happen, you end up getting a perceived devaluing of these companies, even though the value of what they're building is still there, but the perceptive value goes down because the investors really just want to get out because they've been inappropriately educated by the leaders on the board. So, a lot of this stuff comes down to simple communication, but long-term stakeholder alignment is really, I think, by proxy reflective of alignment to the board of directors. And in this case, I mean, what's good about this is that our timelines, really are not 7 to 10 year timelines. They're kind of forever timelines, all right, look,
there's not an exit horizon in the same way. We want to exit to community is the term that we've used. Like if we want to solve these problems, these are long entrenched wicked problems that we have to, we're going to have to go after for a long time. But if we're exiting, it means that hopefully that we've solved the problem in a sustainable way or found a way to solve it sustainably.
Yeah. All right. So look, I just want to touch on, what's Braided? What is it?
Yeah. So Spear touched on this a little bit, but it is our sort of hopefully end-to-end solution for some of the tech needs that exist in trying to address social need in these communities. And so it is an integrated um, case management tool that is also an electronic health record. It allows small community-based nonprofits who are doing some of the hardest work possible not have to replicate their efforts across multiple different platforms, because they can now do it in one unified system. It allows them to meet the clients where they are, do the case management work that they're doing, and also tag it for the billing that they would need to do to submit it into Medicaid, Medicare, or healthcare overall. Um, we've seen, we've been on the ground, we've been working with folks for a long time. A lot of folks have access to other platforms. The health plan provides them with a free license or something like that, or they've gotten it some other way. They don't use it. It's out there, just not being used. And part of our understanding with that is because they also have 5 other platforms that they have to manage. And they're all they're documenting the same thing over and over again in these 5 different systems. But they're going to pay attention to the ones that actually pay them to do it. Because you're getting money from HUD if you're a housing case manager, or now you're getting money from Medicaid, so you need to pay attention to that one too. But so we figured out a way to unify those systems together and allow them to do multiple financing sources in the same platform, and really try to streamline a lot of that work for those end users, being the case managers themselves, who are doing this work in tandem with the nurses and doctors who are doing the work too. Our ideal for this is to get local communities empowered as like a health hub. Essentially, you have your hospitals, your medical providers, your homelessness providers, your food service providers, all using the same platform, because they're seeing the same clients who are unhoused. They're also the same clients who are food insecure, who are also in the emergency room. How do we make that a lot easier for all the members of that care team, not just in the hospital, but across the community overall?
Awesome.
And I'll add one more piece to this, is that I mean, I can't say that, oh, it's the best platform out there and everyone should use it per se. However, it's community owned, it's community funded, community sourced. However well it does, our communities will do just as well.
Yep.
As owners, as co-designers of this platform. I think we've, again, goes back to our conversation, we've seen tons of SaaS models out there in healthcare, in the SDOH spaces, all of which are generating maybe massive returns or not, but to investors in somewhere else. So what does it look like when an actual platform and the returns on that platform are generated for those communities who are the end users of it? And that's kind of what we're setting out to do here.
It's really interesting because it's almost like, between parties who don't know one another, currency seems to be the universal form of trust, right? And when we talk about healthcare, we always often say that healthcare moves at the speed of trust. And, when we think about things changing and innovation, I almost got from being a startup strategic partnerships guy a decade ago and then getting into company building while doing my executive search business, the word innovation started becoming like, oh, really? Whatever. I don't even know if that is real anymore, right? But it's interesting, right? Because, really where we're aligning is at the bottom line. You know what I mean? And, that speaks volumes. So, look, guys, I don't know about you, but this was really fun for me. I love this. This is awesome. So I guess as a parting thought, where can people go find out more information about you, and who are you guys looking to meet and talk to further your mission?
So you can find out more about us at FwdSlash.org, FwdSlash.org.
Yeah.
I mean, I think we're doing this work. We want FwdSlash to do well, our communities to do well, but we also want to just change and demonstrate that there's a different way to do this. The times are calling for just different ways to address social determinants, to expand access to healthcare and Medicaid and housing supports and housing supply. So, anyone and everyone who's trying to solve or claims to try to solve some of these more wicked problems, as Josh mentioned, there are different mechanisms outside of the sort of classic VC startup structures. There's a time and place for them, absolutely. But if anyone's kind of struggling with, getting mandates from groups they don't believe there's aligned accountability from, or they're looking for, they came into this space to solve problems other than 7 to 10 year return horizons, we're happy to talk to you, happy to show you. And we have no there's no NDAs, there's no walls around our work and IP. It's groups ask us to sign NDAs. We're like, what are those? Like, go ahead and solve homelessness if you want to. So truly, anyone that's looking to solve some of these harder problems and looking for other ways, we'd love to talk to you.
Yeah,
And
I
I'll
echo
go
that.
a step further. I'll go a step further and say, yeah, you can go to our website, but also come meet us where we are. So like we're out doing events at a high level grassstops thing. We're trying to pitch in front of people all the time, but we're also out and down in the community with the grassroots folks doing the important work. And we're always in our communities across the country. And so if you're in one of those communities, you want to like learn more about how you can plug in, or if you have a similar community, we'd love to explore that with you. So yeah, just come join us on the journey.
Well, it's been an absolute honor to work with you guys, and really, at the end of the day, work with some of my really, really dearest friends who are doing something awesome, and I'll be doing this with you for my entire career. So thank you so much for being a part of my podcast. This is Mark Czubachowski with MCZ Align, and this has been episode number 5 of Align Health Insights. What a treat. What a pleasure, gentlemen. Thank you.
Thanks, Mark. It was awesome.
Bye-bye. Wait, you could